everyone, it's me, Dr. Smearmon, GynoGirl. Thanks for coming back to GynoGirl Presents Sex, Drugs, and Hormones. I'm super, super thrilled today. I have so many great people in my presence right now. I have Heather Quaile, who's going to guest host with me. You have your own podcast.
Yes, Just Ask podcast.
Just Ask podcast. Well, we have a dream come true. We have a dream team here today. I'm going to do it like Oprah. Welcome, Sue and Irwin Goldstein. They're amazing. They are the real masters of sex, the OGs, the everything. But this is a real honor and a privilege, to be among you. You guys have always been welcoming. Heather and I both did preceptorships with you guys. And so we find that, there's nobody like the Goldsteins.
No, there are sex med parents. That's what I tell them.
Absolutely.
Well, we love both of you. So thank you so much. We're so honored to be here with both of you.
We are amazingly honored. Thank you so much. It's so cool. We're going to have so much fun right now.
I know.
Yes, can't wait.
Heather and I are at the Menopause Conference, so that's why we're together, but it's great. We're going to get into it. We want to start with the first story. Like everyone, I've told the story in my own way, but I want to hear it from the mouth of the two of you. Like how ISSWSH began. Start with the Viagra story.
Give us a little history.
Because ISSWSH is going to be 25 years this year, right? So.
Well, ISSWSH itself isn't 25 years. The start of what became ISSWSH is 25 years. But yes, Irwin, the floor is yours.
Yes.
No. You tell the story better, to be very honest.
Okay. So Irwin was the key player, but I'm the storyteller. Okay. So in 1998, when sildenafil, Viagra, was approved, the New England Journal article came out about sildenafil, which was the first time anything like this had ever been published in the New England Journal article. And Irwin was the first author. And he started getting calls from women saying, okay, you've done this for men. What are you going to do for me? And it's like, well, I don't know. And he said, go talk to your gynecologist. And referred them to the gynecology department at the medical school where he was working at the time. After, I think, about 6 months.
University, right?
Sorry?
Was that Boston University?
Boston University School of Medicine.
Yeah.
And then, like 6 months later, Irwin called the department chair and said, well, what are you doing for these women? He says, I don't have a clue. I'm going to make you a professor of gynecology in addition to being a professor of urology. He said, okay, but he really didn't know a lot. And he thought, well, if I bring in world's experts on all the little different pieces and we sit down in one room, maybe we can start to figure it out. And so he convinced the university to have a CME course for women's sexual dysfunction. And he brought in people from around the world and they all in the room, they presented, and a lot of us were in the audience and listened and said, sort of an aha moment. And then he did it the next year and brought in more people, and it was still a course. It wasn't a meeting. And he said, oh, you know what? So many of you are interested. Do you want to become a society? And everyone goes, no way. So then the next year he did it again, the third year. Said, do you guys want to be a society? And everyone said, you know what? Yes. So that was the start, and it was named the Female Sexual Function Forum. And the next year, with our first board of directors and everything, somebody said, female can imply human and animal as well, and we're really only interested in women. And so it was renamed the International Society for the Study of Women's Sexual Health, and that's how it was born. And what's crazy about it is every other group is a medical society, but the rest of us are not physicians. And Heather, you and I can both relate to that. We're sort of secondary citizens. We're research society that's all PhDs, and the rest of us are secondary citizens. And this, we said, we couldn't exist without a lot of people, each contributing their little piece of the pie to make that pie whole. And from the ground up, the bylaws were built that we all have equal import. And that's why today, ISSWSH is such a strong society, because it doesn't matter what you do, as long as you are somehow involved in women's sexual health, you are welcome in ISSWSH and can have an opportunity to contribute.
100%.
So our first president was Sandra Lieblum. I don't know if you know her, sex therapist in New Jersey. And she was the one who actually officially first ever described PGAD.
Yeah.
It was PSAS at that time, but when it was close enough.
It's just
she eventually changed it to PGAD.
Such an inclusive society. Like, I just kind of want to go on and on about why it's so important to have like the therapists, the sex therapists, the physical therapists, the doctors, the educators. Like there is a place for everybody in this society.
And that's because medicine's biopsychosocial, right? So we need all the aspects to move it forward.
We have had nurse practitioners on our executive committee. We have not had a nurse practitioner president. We've had sex therapists, PhD. We've had
your role, Heather.
We've had MDs. We've had educators. I was the first president who didn't have an advanced degree. So we've really, gone the gamut, but we haven't had a nurse practitioner and we haven't had a physical therapist yet. As president, we've had a nurse practitioner in leadership position, but so we're looking forward to what the future will bring.
Next
By the
up.
way, May 14th, 1998 was the New England Journal of Medicine article, and that spring to 1998, and we had a fellowship provided, and the fellowship came with a sex therapist and a urologist in that year, sort of the fall of that year, and we started seeing women. So I have 10 clinics, 5 in the morning and 5 in the afternoon. I actually had lunch sometime in my life, which is kind of interesting. Don't have lunch anymore. But we did one clinic out of the 10 for women. And within 2 or 3 months, we had equal distribution of men and women. That's how popular it was to start to see women. And
Right.
our initial management plan was to treat them exactly as we treated men. We drew all their testosterone bloods. We did Doppler ultrasounds. We had a therapist. And it was very successful to some degree, but it ended up that we with ISSWSH's blessings and all this stuff, we ended up doing vulvoscopies and all these other things.
We had a lot to learn, and we're still learning. And that's what's exciting, is that the field is still new enough that everyone has an opportunity to make a difference, to discover something new, a new diagnostic test, a new way of doing surgery, a new medication that are current an FDA-approved medication for one thing that's going to work for something else. There's so much left to learn that the field is wide open for people who are interested in developing new methodologies and things.
Interesting story. We have a USC medical student taking a year off to do research. She wants to go into urology, so she's working a lot with us. And one of our projects is to actually formally describe the vestibule. Now, I know that sounds pretty weird, but I'm going to say things to you you don't even know. So the urethra of a woman.
Stop for a minute, because the people watching this podcast don't even know what a vestibule is. So let's stay with that. Let's get there.
I talked about it before. Just reintroduce them.
Tell us what that is for all our people.
The lobby to the theater.
There you go.
The foyer
to the house.
To be able to get to the vagina. Right.
It's the of the embryologic structures. The ectoderm is the skin on the outside. The mesoderm is the reproductive area, pretty much. And then there's an endodermal component that bridges the gap between the two. And we're talking about that bridge. But anyways, we now do vulvoscopy with a ruler in place, so we can actually determine exact measurements of things. And there is a urethra in the middle of the vestibule. It's kind of the epicenter of everything now that I'm understanding it better. If you look at a man's penis, it has a urethral meatus surrounded by a fleshy tissue called the glans. And we've never thought of the urethra surrounded by a fleshy tissue in the woman. So there's like a glans clitoris, but there's actually a periurethral glans in all women. And we're now starting to describe it and better understand it. And in cases where it's painful, we're removing it. And we can now determine it's not urethral tissue, it's vestibular tissue. Because it has nerves and mast cells in those people. And it's called periurethral glands. And we're determining the size and dimensions in the next generation of women. Off the superior portion of the periurethral glands are spokes, little flaps that come off in a majority of women. And we're describing the angle and their purpose. And in between it's in a 12 o'clock position. There's multiple minor vestibular glands, really never been described before. Well, I think the whole point is, Sue's saying we started with the Viagra in 1998. It's freaking 2024, and we're still describing anatomy. Think of that for a second. How the hell could we not know the anatomy? But we don't.
We don't. Anybody studies it, right? So.
And no one is taught to look at the vulva. Like you're just taught, the vagina, here's a speculum, it goes
right
inside.
Yeah.
How many patients come to you and say, my vestibule hurts? They say it hurts down there, or they say my vagina hurts, even though it's nothing to do with the vagina, because patients don't know when they come in, and we do such a disservice by not teaching them the real anatomy. I mean, what man with scrotal pain comes in and says it hurts in my penis? A man knows the difference between the scrotum and the penis.
Yeah. Exactly.
I have a quick story. Quick story. woman yesterday with vaginismus. Okay. Never, of course, did a vulvoscopy, and her legs would 100. I know you've done these exams. They 100% come together.
Right.
And we're doing the study with the vulvoscope, and her eyes were closing. She put a pillow over her head so she couldn't see. We finally asked her to open her eyes and see. We gave her the Q-tip under her own control with no one else doing it. She was able to do the exam. So the beauty of vulvoscopy is not just to it's to allay fear and provide education to the anatomic structures that are otherwise not seen. And it was so beautiful to watch her do this. Whereas when I tried to do it, the legs came together and, the anxiety was there. But when she was in control, she could do it. I thought that was very cool.
I did too.
It just goes to show how much medical trauma people endure over the years, like over and over.
God.
It's not even like
Not even to imagine beyond
No
that.
patience. No patience in women with pain. No patience.
No.
You got a 7-minute window.
Yeah, and you're
And-
like, it's fine, open, you're good.
You're
Let,
good.
let us just shove this in.
Shove
there.
it in there.
It's 2 seconds. You're fine. It doesn't hurt.
You know what
And
I
if
find
you-
awesome is that you are a urologist, and your paradigm was always men, and so you put that paradigm onto a woman. Whereas, like, gynecology is still so patriarchal that I'm a product of this learning. And I think I've told you before, like, we learned the cervix has no nerve endings. Do whatever you want, like all this BS stuff, and it's because like it's like this was women's health, but the paradigm was women, and so it was just different. Like you just treated them
Yes.
differently because of patriarchy, misogyny, whatever you want to call it.
And they know they've been gaslit. They know that, but they don't recognize how many women experience it. They think they're the only ones experiencing it. So it's, like at ISSWSH, we always talk about just asking that question gives them permission that they know it's a safe space. So
Right.
starting that conversation and knowing that they are not alone, that in our office, the men have typically been to 4 or 5 physicians before they come to us. The women have typically gone to a dozen clinicians before they come to us. I mean, that is ridiculous.
Telling.
Isn't it?
By the way, yet another story. You brought up urology versus gynecology. Guess which society, and I'm going to say it's the American Urological Association, will make the first ever expert panel management plan for women with GSM, genital urinary syndrome of menopause.
course,
Which
AU, right?
society will do that?
Right, for sure. Yeah.
And it's going to come out next year, and it'll be groundbreaking, earth-shattering, finally giving attention to this area in a manner that's based on they actually spent more than $1 million doing a collection, like a meta-analysis of all the data. Amazing work.
The AUA has had courses in women's sexual dysfunction for 20 years. And over the last few years, it started out with just the one that Irwin taught. But over the last few years, they have multiple courses. How many courses in female sexual dysfunction does ACOG offer? And does the Menopause Society offer? Nothing.
No.
Nothing.
What's interesting is that they posted the original GSM article by the 12 consensus societies, and we know
In
which
Chicago.
Yeah. And we know which society's not on there. A lot of the gynies in the office were like, the audience were like, oh, ACOG's not on there, but the Royal College of OBGYNs is. And I was like, well, that goes.
Interesting.
Anyone who
I
knows,
was a panel member. Wow.
he's the only urologist in the room, and tell them why we have the name GSM.
Okay, so GSM was founded from vulvovaginal atrophy, vulvovaginitis, weird, horrible. It didn't include the anatomy was incorrect, vulvovaginal, but the problem is primarily vestibular, and vulvovaginitis. None of that was useful, and it was demeaning to women. So we put together ISSWSH and, was at that time the North American Menopause Society, now the Menopause Society, put together a meeting in Chicago. I'm going to say 2016, but
I think it was published in 15. I think the meeting was 14, or published in 16. The meeting was 15. I can't remember.
A few days ago. And so it was urologists were not invited. I was the only, but I was invited as sexual medicine, but I'm a background of urology, and the new name was going to incorporate things like the vulva, the vagina, maybe now the vestibule, but there was no attention to the urinary symptoms, and it was very annoying. because the lower urinary tract changes dramatically during an atrophied situation. So after a lot of discussion, we sort of got rid of the genital only concept and made it into genital urinary. And that was a huge advance because that got the AUA involved. And the
Right.
AUA is now making the guidelines. And that was a huge breakthrough. It took a few years for GSM to become popular. People were still using VVA and stuff.
Yeah.
But it's really pretty
Like,
much there now.
Yes.
nobody wants to be told their vagina is atrophic. Okay.
Yes.
Yeah, there you go.
Well, the equivalent in men was the impotence was the term, and the
Yeah.
NIH said that's a pejorative term. And in 1992, they put together a panel because Irwin was part of that, and renamed it erectile dysfunction, which allowed us to now have a disease state that could be, successfully treated. But no one's ever stepped up for women until
No.
now, really, with the AUA. So.
Yep. And
Let me-
even still, we need more changes to the GSM name because
Right.
it's outside of menopause. I mean, we had a poster at ISSWSH. It's lactation,
hormone
it's
deficiency.
hormone deficiency. It's in our transgender population. Like it needs to go just beyond the word of menopause.
I think after the guidelines come out, it'll be easy to flip them to other similar types of guidelines because the treatments will be the same.
Right.
Yeah, I think that's the key because it's still going to. I mean, GSM still refers to people in menopause, but the point is that we can then say women lactating have the same hormonal loss of hormonal support, and and compare all the various things. They have the same, and so that should be the same treatment guidelines because it's the same hormonal. You can't change the name necessarily to include all of those disease states because it's really quite different, but. The Menopause Society is so busy worrying about bone fracture and hot flashes. And, when you treat them the way we treat them with hormones, then they don't have the issues with the bones in general. I mean, I'm not going to say everybody, but we still live in a world where people think that menopause ends when the vasomotor symptoms are done and then you go into postmenopause. Well, your ovaries don't suddenly start to work again. Doesn't matter what you want to call it. You're in menopause or postmenopause the rest of your life.
Yeah.
I have a story, a cool story. You're at the Menopause Society. So this woman comes to the office and she's 85, okay? And she meets this guy who has a penile implant and at a nursing sort of wherever they are.
Senior village.
Senior housing, whatever you want to call it. And they fall in love. It's really sort of cute.
I love that.
But she's sore and tender. She goes to her internist and her gynecologist and whatever the hell. No one wants to treat her because she's 85. And the guy who had an implant knows me. So he said, well, he does men and women, go see me. I said, I don't understand why we can't treat 85-year-old women. What's the difference? You have all the anatomy. Well, they said, you're too old and this and that. I said, well, we'll just take more monitoring care of you. We'll see you more often, but I don't know why you can't do it. Anyways, she's now, she's in pain-free mode now. And it's sort of cute. It just goes to show you though, that some of the take-home messages from WHI are just so awful and they're incorrect and they set up a standard that shouldn't exist.
100%. If I'm 85 and still able to have sex and I need hormones, then
come see me. I'll still be there.
I'll die happy. I will die happy.
Absolutely.
You're not going to be practicing medicine anymore. Trust me on that one.
Yeah.
But Sabina will take care of them.
Right. Irwin, I was going to ask, did you, just as a side question, did you ever think Viagra was going to be as big as it is when you were doing it? Because I never asked you that.
It's a question that was extremely obvious because through the millennia, cavemen, Egyptians, all the writings showed a man with his sort of an anatomic part going down. So ED has been a part of all life, and it was obviously horrible, and there was no easy solution for it. And when this pill came out, it was the biggest thing in a man's life ever. And this just rolled through the FDA. In 6 months. This was approved. Think of that. You want to get testosterone approved for a woman? They mandated a 10-year safety profile. So this just flipped through because there's men at the FDA, I gather. Whatever the reason is, it just flipped through it. But Yeah, it was going to be big, but we thought it would be bigger. We spent a lot of time and effort and money in developing it for women. We just
Mhm.
didn't know how to run the trials. We
Yeah.
just sort of said anyone can do it. We didn't realize about pain. We didn't realize about HSDD.
Yeah.
Excuse me, low drive, low interest,
Right.
which is a big problem. And
Hormones you didn't take into account. Hormones,
no,
hormones.
we drew hormones. We definitely drew hormones,
But
testosterone
did
and
you
all women.
exclude people that based on
I
hormones?
think the issue is arousal is arousal is not a driving presenting symptom, and
That's right.
if a clitoris, the physiology of the clitoris is engorges. There's no question it gets larger during sexual arousal. There's lots of studies showing this. But if a clitoris engorges less, or only 10%, whereas a man, that would be a disaster.
Yeah.
It's still sensitive and it can still be orgasmic and provide pleasure. So,
Mhm.
so it's not perceived in the same way. So the drug never had a chance, but it could have been if it was really a home run for both genders. This would be the god of all medications.
Yeah.
The
Yeah.
Ozempic of current time.
Well, that's exactly where I was going. My head is, I'm like, was Viagra as big as GLP-1s? Yeah,
It
yeah.
could have been.
I think it could have been. So Samina and I know because we get to know what's coming up for the conference ahead of time. But can we talk a little bit about this exciting paper that's coming down the path
Like,
that
what
you're
can you
doing?
tell us about
What
this
can you
stuff?
tell us about the big O paper?
The
That's-
orgasm.
Oh, the big O paper. Oh, it's so fun. You have
Yeah.
no idea what we're going to be doing.
The little
We,
teaser.
we,
for
uh,
conference.
He's our
Barry the genius, Dr. Barry Kamazarek at Rutgers University, neurophysiologist and really master of orgasm. He has multiple textbooks on it, multiple papers. So we have this 19-person committee, which is just outstanding and just so much fun. And we're slowly putting together, and I have to bless Sue for being the driver to put it all together. But what we're trying to do is make an impact like we did in the persistent genital arousal, genitopelvic dysesthesia paper, where we sort of made an inroad where we could say these conditions could happen in this region and this region and this region and this region. And we sort of made a region-based a way to classify the different symptoms. What we're trying to do is to say, okay, you have an orgasm dysfunction, but maybe Mrs. Jones's orgasm problem is different than Mrs. Smith's, is different than Mrs. Whatever. And the point is, we've now divided orgasm dysfunction into 5 different conditions, which is so exciting. And we've developed a strategy that's, well, I mean, there's lots of different strategies, but if it gets to the pharmacotherapeutic realm, there's going to be a specific strategy for that realm. So it's basically failure to excite,
No, just
failure
leave the teaser. Just leave the teaser. Let them
failure to inhibit,
So
failure to excite and inhibit are the 3 major ones. So you climb the mountain, but you can't get high enough to get to the other side. Failure to excite. You're climbing the mountain. In the process of climbing, it becomes hyper intense, becomes painful. You can't go any further. Failure to inhibit. Failure to excite and inhibit. You're climbing the mountain. It gets a little intense. You have a premature, unwanted, muted version of an orgasm. We call it the anthill because you never make it up to the mountain.
Right.
Then you have these pleasure anhedonic situations. Then you have the post-orgasm illness situations. We have names for all these things. But by simplifying it, by making it sort of what people can relate to, it's been so cool. We're
Yeah.
going to create a way where you can listen to a woman with an orgasm dysfunction. Oh, you have failure to blank, and here's how we're going to treat it, and we're going to get better for you. And that's never happened before. That's so cool.
So he's going to actually, so for our listeners, he's actually going to be presenting it at our conference. So you need to sign
Go
up.
to ISSWSH.
Yes.
Swish it.
Yeah.
And we're super excited about it.
Yeah. So basically, all the issues around, a woman's orgasm and how it becomes a dysfunction for them, bothersome for them. That's what we're going to be dealing
Yeah,
with.
you're going to change the way you do this. I'll teach you one as soon as you want. Listen, one little story is my wife was in her late 40s, and she grabs my shoulder, and she's not happy with her hot flashes and all that. And she looks at me and grabs me and says, "You will stop these from happening." And I'll never forget that. And that forced me to learn how to do menopause. And it's now 20 something years that she's on menopause management. And she's vibrant, she's excited, she's sexually intact in a major way. And yeah, it's Sue that's driven my forced me to study and understand and learn and manage this amazing condition. Menopause. It's so much fun. It's so easy to treat, and the treatment restore. You take these tissues, they're pallor, they're erythematous, they're raw, they fissure, they're atrophied, and with management, they all return back to pink, lubricious, healthy, stretchy. They don't tear anymore. It's it's the coolest thing. The tissues maintain their enzymes. They're just missing their substrates to start making the hormones within the cells. I have to tell you, it's the coolest condition on earth.
It really
It
is.
really is.
You can the fact that you can restore it and make it back to functional is amazing. Tell us a little bit about what research you're doing down there, because yours is the biggest, I think, sexual medicine research base in the country, I would assume.
So do some stuff. What do you want to talk about?
So we've got don't have a lot going on right now. We're almost finished with a trial of a device called Imcella that does 11,200 Kegels in 28 minutes. And we're looking to see if with strengthening the pelvic floor will allow us to have better orgasms. So that's the study that's almost done. I'm trying to just talk about the female studies because you're not interested in the male.
Can you give us a sneak peek? Like, does it look like it's helping?
Oh, there's definitely people who have better orgasms. By the way, if you have never sat on this crazy device, please do so.
I sat on it at your office.
OMG. And we just had a guy just yesterday. He has.
You done it for any men? Like off.
Yes, so we're doing it for men. And this guy had great difficulty peeing. His pelvic floor was extremely tight. I said, I don't know if the Imcella would work, but let's just try it. And he got off the Imcella, went to the bathroom, and said, "Holy Christ, I have a great stream. Everything's relaxed." And
it's not supposed to be for high tone pelvic floor. I mean, we won't let women on it with high tone pelvic floor. And in fact, the company is trying to develop a different protocol because it's computer driven within the device that is for high tone pelvic floor. So we should tell the company about this because that will help inspire them. So I don't know how this is happening because it strengthens the pelvic floor. Somehow, I guess it must have just broken up the knots and his muscles or something to relax. But
tell you about the cooler project that we're doing. Can I do that? Am I allowed to?
I will stop you if it's something confidential, and if it's the one.
Oh, no, not confidential. It's fabulous. So there's this amazing provoked vestibulodynia problem beyond hormonal called neuroproliferative, and I don't know how common it is in places where surgery is commonly done. You tend to see more of it, but I think that's just a biased perspective.
They're coming to us specifically because we have the expertise, so we see a lot of people.
It's a horrible dilemma because you can't see the pathology. It exists underneath the skin lining. It's in the submucosal stromal layer, the nerves and the mast cells. So there's just so many nerves that just basically doing an allodynia test, which is just a stroke test, causes huge pain, whereas a stroke test should just tickle. But that's a separate question. So the question is, we're doing surgery, but we're not having a diagnosis in anyone. There's no preoperative requirement to state that they have too many nerves and mast cells. We're doing the surgery. In our facility, everybody gets nerves and mast cell staining, but we only give them their confirmation, say 3 or 4 weeks out. It's not logical to operate on people.
Diagnosis of exclusion up until recent knowledge that now has changed the way we do it.
So we're trying to figure out how to get a biopsy of the tissue. But remember, if you biopsy an area with nerves and mast cells and it bleeds and you put stitches in, you're putting these people out with a huge amount of pain for a long period of time. So there's got to be a way to do that. So we're struggling, and we're looking at the hymen. And who the hell has done any research on a woman's hymen? So if you actually look carefully at the anatomy of a hymen, it starts, the vestibule starts at Hart's line. And theoretically, the vestibule ends at the hymen, but it's actually not true. On the other side of the hymen is an endodermal vagina, which then leads to finally a mesodermal vagina. There is this entity below the hymen that is still endoderm. So if you conclude that the hymen resides above and below it as endodermal, a biopsy of the hymen is something that's stupidly simple. It's not painful. It heals quickly. So what we did in our last 20 vestibulectomy specimens, or our plan is, I think we've done 13.
We've done 13 so far.
Take out the specimen, and then as the specimen is taken out, take out the hymen from the specimen and send it separately for nerves and mast cells. And all 13 have shown nerves and mast cells. And the last bunches of hymens from specimens, we've taken a little biopsy gun rather than the whole specimen. They've come back with nerves and mast cells. So I have a whole bunch of women. One of them is 61. One of them at 12 years of age, currently now 61 at 12. She couldn't put a tampon in. She couldn't enjoy sex, couldn't have a spectrum. She's just like these 20-year-old kids with this classic condition, but she's 61. And she said, you can't operate on me unless you have a diagnosis. So we did a little biopsy of her hymen.
In the office.
Yeah, because we just started this concept. But we're going to change the paradigm of this entire management for this condition. That every human being who is considering surgery should only do it if there's evidence that they have the condition. It only makes sense. And a hymenal biopsy takes less than 10 minutes. We put 2 stitches in. It completely heals. I have before and after pictures of the biopsy site. And that's really an exciting advancement.
Test elicits pain, but people have hormonally mediated vestibulodynia will also have pain with the Q-tip. What he does is he takes a Q-tip and just very softly rubs it. And and so it should feel the same on your vestibule as it does in your hand, unless you have neuroproliferative vestibulodynia, and then you want to hit the ceiling. It's painful, it's burning, it's some kind of massive reaction just from a very light touch. And that's the big difference between the hormonally mediated and the neuroproliferative that we're finding. But we're not
There's
yet.
one other condition that's positive with the allodynia test. Do you remember it?
I don't know what else it is. Not lichens.
Not lichens.
No, I don't know what else.
All right, Samina, Heather, tell me the answer. Blah, blah, blah. We see a lot of it. Dr. Kim is involved. It's called sacral rad.
Radiculopathy.
There you go. Radiculopathy. If you tickle it, it will cause pain.
Yeah.
Those are the 2 only
It's a
conditions.
nerve disease. They're both nerve diseases.
Yeah, that's the point.
So if you touch,
Anyways,
so if you actually touch the hymen with the Q-tip, it could be neuroproliferative or it could be hormonal.
if you tickle the hymen, she will yell at you.
Yes.
And just
See, the hymen's a flap. You can easily put lidocaine in it, 2 seconds.
Yep.
You take your pickup, just cut around the pickup, send that tissue out, put 1 or 2 stitches in. They're done. It's over. And then in 3 weeks, we'll have their diagnosis. And every one of these has shown positive if it's truly conditioned.
And if you're trying to differentiate between neuroproliferative and sacral radiculopathy, if you numb the vestibule and it stops the pain, then it's either neuroproliferative or hormonally mediated. And you've used that tickle test to determine that difference. But if the vestibule is still painful, then obviously it's coming from someplace else. That's when you suspect sacral radiculopathy. Although we do a bunch of neurogenital tests as well to support that. That would never be enough information to address the back. But
What about
I think you both, Samina and Heather, need to move to San Diego. We'll all work in the same facility.
I would love it.
I would love it. I tell you this all the time. Love it.
wait a minute, Samina's husband is pain management. He couldn't work in the
Oh
middle.
my God, we could make him a millionaire there.
Yeah. Let's go. I'm ready to move.
Retire to Chicago. I'll come out here. We'll meet in the halfway middle. Though their place in San Diego is so beautiful, they're never going to leave. I wouldn't leave either if I was there.
Well, Irwin, back to when when you take the hymen biopsy, do you actually what are the pathologists staining it for the people that are listening?
CD117, which is a stain that's consistent with mast cells, and PGP 9.5, which is a stain consistent with nerves. And we've done hundreds of these things.
Because I actually asked one of my pathologists because I'm about to do a vestibulectomy, and he said I could probably do the CD117, but the PG one, he was saying that something
that gets sent out. The hospital doesn't do that. They get sent out to a specialty facility.
I think it's in Chicago where it's done.
No, it's not in Chicago. And the other thing is that normally your insurance will cover the H&E staining that's done in the hospital. And if they do CD117 in your hospital, but the moment it's sent out, the insurance won't pay for it. So either you have to pay the additional fee or your patients have the additional fee, just so you know. It's not all that expensive. But
guess what happens if you stain endometrial tissue with CD117 and PGP 9.5?
Lights up, right?
Nerves and mast cells, lights up. Yeah, it's the same condition. That's
we have patients.
So crazy.
We have patients with multiple mast cell aberrant activity conditions that have had surgery of endometriosis. One had colon, and so we've sent all of that out, and it's all looks the same.
It's amazing.
All right. Well, this is an ISSWSH abstract. My abstract girl right here.
Oh, that's awesome. I'm
so excited about this. This is exciting.
We didn't even let you guys ask more than 2 questions today. Sorry.
Well, can you tell us any of the other stuff you're doing?
I know. I'm like, what kind of abstracts are coming down our pipe? This is me as a.
We have to write our talks for the ISSN meeting in 2 weeks, and then we have SMSNA in 5 weeks, and somewhere in there we have to write all our abstracts. So I
get them all and do all the things. Yeah, we got a lot of work to do before the end.
We've never submitted less than 8 or more than 12, so you can look for a bunch.
Oh, wonderful.
Have fun with
wonderful. Oh gosh. You guys are so great, actually. And so what else do you guys offer, like, at your center? I know that it's a multidisciplinary center. You're doing your pelvic floor PT.
Sex therapy.
Basically say, if there's anything keeping you from having the sexual life you would like, of any person of any gender, we will take care of that. So all of our new patients have a biopsychosocial assessment. So they meet with our sex therapist who's not performing sex therapy. She's doing an assessment. They meet with Irwin, who does a detailed history, and then either he or the nurse practitioner or our fellow will perform diagnostic testing. But if we're talking about women with low sexual desire that distresses them, women who have orgasm issues, it's either they have post-orgasmic illness syndrome, or they can't reach orgasm, or it's muted. People with pain, we've just talking about all that, but it may not just be vestibular pain, genital pelvic dysesthesia. So any kind of weird feelings, dysesthesia is basically weird sensations in the pelvic region. We deal with that. And when this,
give me 1 second, okay? Yes. I need permission from you, Sue. Permission granted, yes?
Permission granted.
We have this most amazing relationship with the spine surgeon.
Oh, yes.
I tell you, we do many cool things, but it is definitely one of the coolest things. And every Sunday morning, we review cases and go over MRIs and all that. His name is Dr. Quaile Kim. And the brilliance of this man is not to be emphasized enough.
He's presented at ISSWSH before.
Yes,
we have over 200 surgeries now of individuals with sexual problems whose problems generate from their cauda equina, from their lower part of their spine. And success rates are so amazing. I don't know if it's yesterday or the day before, we had a woman who had vestibular pain. We were poking and prodding, and she had a lot of pain. And she had a back problem, an annular tear. We did an injection of lidocaine in her L5S1, whatever her annular tear was. She came back in. I touched her vestibule, and her pain wasn't there anymore. This was a vestibulodynia from sacral radiculopathy. So cool. She had sciatica. She had other symptoms that were consistent with the spine, but it was so cool. She came in, I think it's her 8-week or 8-month follow-up, and she still has no pain in her vestibule. She has no more sciatica. She has no back pain. She has mobility when she walks. This is just an example of so many people whose problems present as in the genitals, and you get frustrated because they don't get better with genital-directed therapy or even pudendal-directed therapy.
Change what to do. I mean, women present what they say they have a golf ball in their vagina, and you put a speculum in, and there's no golf ball in their vagina. Where is it coming from? Or they have clitoral pain, and you're able to retract the hood, and there are no keratin pearls under there. Why should they feel like they have knife blades? They're all sorts of weird stuff, and because you can't see it, they're told it's all in your head. You have trauma. things like that. And it's so
He has so embellished our practice of women's sexual health, Dr. Kim.
Tell
Amazing.
us
Yeah,
story
I want
about
to know the story about Dr. Kim. Like, how did you convince him that there's something connected? He must have looked at you like
a pair of handcuffs.
he was
Because-
like, what are you talking about? And what has women's female parts have anything to do with backs?
Well,
I
just
wanna
to-
know the
Just
story.
to emphasize, like we were talking about the region-based approach to abnormal genital pelvic pain sensations and persistent genital arousal, which I've talked about at another podcast. But this is the region-based approach that you guys have created. But how did if we were in the room where it happened,
Yeah.
how would we know?
Our Hamiltonian moment,
Yeah.
please. And I
definitely
wanted
did not have the same region base. That's new.
Okay, so what
Sue, tell us the story.
Well, I mean, it really started with Barry Komisarek, who was doing an MRI study with Tarlov cysts and found that there was a much higher percentage of people suffering from persistent genital arousal disorder with Tarlov cysts than the general community. And so that became, well, is there something in the spine that's causing the PGAD? But
That was 2016, by the way.
Oh, that was 2012.
Oh, 2012. What do I know?
In 2016, we had a patient from Copenhagen, I think Anna Maria sent to us.
Yeah, 100%.
And she had already been signed up for assisted suicide in Switzerland. But she had been, her family had basically thrown her out of her house because they thought she was crazy. She had dropped out of her PhD program. So, she's an intelligent woman. And I believe it was like a church community group sponsored her to come to America. And Irwin she had this constant buzzing. He did every diagnostic test he could think of. And then at the end, he said, well, maybe it's something to do with the Tarlov cyst. But at that point, she said, I've had enough. I'm out of money. I need to go back to Copenhagen. And she went home and went to assisted suicide and killed herself. And Irwin went with that to Chol Kim and said, you have to help me. We can't lose anybody else with PGAD to suicide. And Irwin, you can kind of embellish the story now.
No, that's that is the story. When we got the MRI and she had a Tarlov cyst, I called Barry, who then referred me to a spine person who said, well, it's going to take 6 months for an appointment and all that sort of stuff. Then I looked around in town in San Diego. Who would do that? No one would do that. And nobody would do it. It was like this horrible thing. And so she committed suicide. And I said, that can't happen. And the crazy part was, because of Dr. Komisarek, we had to do an MRI on everyone who had persistent genital arousal. And the specific MRI was called sacral MRI because that's where the Tarlov cyst was in the sacrum. You got a little peak at L5S1 disc, got even less of a peak at L4, L5, but nothing above. In those two discs, through the spine MRI, we would see countless numbers of people with annular tears and herniated discs. So we said, this is stupid. Why don't we get a lumbar MRI? And then we started saying there's like 10 times the number of people with annular tears who have PGAD than who have Tarlov cyst. But it came backwards because that's the way we entered it through the Tarlov
to listen to him. The irony is Irwin had been recruited to this small private hospital, which has since been sold twice, but been recruited by someone who was a former student of ours. He wanted to bring in some really niche players to offer in the hospital some very special services. And so he had recruited us in 2007. He then recruited Chol Kim from UCSD a few years later. And so Pedram, this person who had recruited us, showed Chol, look, this is the person I recruited. Look at Irwin Goldstein. Look at who he is. And so Chol still laughs about it. He says, when I grow up, I want to be Irwin Goldstein. So he already knew who Irwin was and had a great deal of respect for him. So when Irwin went begging him to please do this, he at least would listen to him. And to this day, as far as we know, he is the only spine surgeon doing spine surgery for sexual health concerns. People ask us all the time, can you recommend somebody nearby? And go, if you find somebody, let us know so we can let somebody else know. But he finally has enough data to present. I mean, he's presented at ISSWSH, he's presented at Sexual Medicine Society North America. He finally has enough data that he's presenting this year for the first time at his spine meeting.
Oh, that's amazing.
So whether he'll be booed off the stage or whether people will want to learn, he's a little afraid of what the response is going to be. But
amazing.
Spine surgeons will say, we don't do clitorises. I'm sure that's what's going to be said.
You've lost your ever-loving mind, but that's awesome.
So do you think it's more in the annular tear? Or are you seeing more of the annular tears causing it or the Tarlov cyst?
By tenfold.
Yeah.
Literally.
much more common. Because think about how easy it is to develop an annular tear. The disc bulge and the annulus leaks out and causes aggravation. So small that a spine surgeon would say, oh, that's nothing, that's tiny. How, you don't have sciatica, you don't have back pain. Because just like erectile dysfunction in the penis is the first heart attack before the vessels get so clogged you have a real heart attack.
Right.
This is the first nerve damage that you get to the genitals, because that's like the first place affected before you get to the point that you have sciatica.
Yeah.
That's actually a very good analogy. I like that. That's wonderful.
I know. She's brilliant. And I want people to know the other things you're doing. Like Samina and I have been so blessed that we've had the opportunity to precept with you. You still are precepting outside of your fellowship, right? You still
come back for more, and then plant all your belongings there and work with us right in the place. Well, it's so much fun.
It's a little more challenging for somebody to go into the OR to observe now because the hospital has been bought by UCSD, but we still make it happen. And we still do. I know we were talking about what we did in the office, but we do a lot of diagnostic testing in the office, a lot of treatments, but we also do more surgeries than vestibulectomy based on what is needed. I mean, that's the bottom line. And, it's a growing field.
He does trans care too. Like when I was there, it was really cool. We got to watch, and I think it's
that.
Well, he
One
did
of the better parts of my life.
Yeah, and it's really sad that people need to go in the prison system to get their hormones. So talk a little bit about that amazing stuff that you do, because I got to actually experience that when I was there, and it was
So when individuals are 3, 4, and 5, they're sort of liberated to do whatever they want to do. If they happen to wear their mother's shoes and dresses and put on makeup, and they happen to own a biology of a penis and testicles, they're in an awkward situation, because when they look at themselves without clothes, they're not happy what they see, because their brain is where what they're playing with. Now, as they grow up, they get struck with society's rules, parents' rules, religious rules, and all that, and then they get outcasted and they end up on the streets. All they want is hormones and care. They're just normal people who are really nice, actually. So they become people own them in a way, and they do bad things and they get into prison. But in prison, they can be outed and they get protection, and so I get to take care of them, and many for the very, very first time. So the privilege and joy of taking someone who knew who they were from day one. This was no choice. This was who they biologically are. And to convert them to being happy on the outside, what they know they are on the inside. It's such a joy.
Match the inside.
I so enjoy that.
And there's
do you know that if we look at the homeless youth in America, and you take away the ones who are homeless with their families and just the single homeless youth, somewhere between 70 and 80% of those homeless youth are gay and trans or LGBTQ, because they don't have parental support. They're thrown out in the street. And it's such a shame, because they're good people with good hearts, and it's not their fault that the biology doesn't match their anatomy.
So they're increased risk of homelessness and history of runaway, and they're also at increased risk for trafficking. So that's near and dear to my heart.
Yes, it is so sad.
That's so sad.
But the state of
we help them on the side of it. We do help them.
But the state of California has made a commitment that all trans people in the state of California prisons are entitled to care. And
I love it. That was probably one of my favorite things and I got to do so many cool things when I was there, but that really pulled at my heart a lot.
Yeah. Okay, so tell me one last thing, because I don't want to be cognizant of you guys' time. So we want to if you can talk a little bit, because we presented on shockwave therapy and the use of shockwave, because you've been doing it in men and now you've been doing it in females as well. So tell us a little bit about like shockwave therapy.
Well, Sue and I, you have to hear this. It's not specifically gender related, but it's orgasmic when I tell this story. It was orgasmic me hearing. Sue and I celebrate our 50th wedding anniversary by taking a river cruise from Switzerland to Amsterdam. And when we arrived in Amsterdam, we go to a meeting called ISSWSH, which has now become one of my favorite societies, International Society for Medical Shockwave Therapy. One of the very first lectures, we start at 8 in the morning and go to basically the evening. and it's shockwave of this organ, shockwave of that organ, shockwave of this organ. And it's dramatically exciting, I have to say. It's such a cool thing. One of the first guys, his name is Holfeld, Holfeld. First name is Johannes. And he stands up, he's like 6'5", cardiac surgeon,
Cute ladies.
really very a younger guy, and he opens up his slide showing a beating heart during coronary artery bypass graft surgery. That's what's on the screen. And he takes his shockwave device and beats the goddamn beating heart with his shockwave machine. And he then gives the story that these are mostly people they have myocardial infarction. Their cardiac muscle has died. They have extra connective tissue. Their ventricle is going like this rather than squeezing it out. The left ventricular ejection fraction is really low versus in a functioning heart. So he then gets the shockwave. He doesn't know if he's getting sham versus active shockwave. He does one treatment, 500 shocks to the beating heart, does his coronary bypass graft, closes the chest, they recover. And at 2 months and at 12 months, he does left ventricular ejection fraction studies. You want to guess what the results show?
That is
Yeah.
improved in
Those people who actually received active treatment have amazing increases in left ventricular ejection fraction. The only way that can happen is if he, first time in history, Nobel Prize, I hope, winner, shows that you can regenerate cardiac smooth muscle with shockwave. That is pretty amazing.
Claims that they were forced to shut the trial down because it wasn't fair to the people who were getting sham treatment not to get the shockwave. And now in Austria, all people getting open heart surgery get shockwave. One treatment.
Wow.
Yeah, so it's called mechanotransduction. When you impose a shockwave to a tissue, it contracts and expands. It does this movement back and forth. And that mechanotransduction changes the biochemistry of the cell. It makes mitochondria, it makes growth factors, cytokines, and all these things. You make downstream stem mesenchymal cells that grows cardiac smooth muscle. We're proving that it grows muscle in the penis in men with erectile dysfunction. And that's another study. Actually, Sue is first author. She just
what could we do?
That yesterday or 2 days ago.
Yeah, so
the 3-year studies that she did, a prospective trial.
Based on this heart study, it shows that the improvements continue over time. So one of the things we're doing is we shockwave our women who are having a vestibulectomy once the day before a vestibulectomy, and we have found that they have less opioid needs. Is it because it's healing more quickly? Is it because it decreases the pain? Is it, we know it's biochemical changes that continue over time. And so it's really been remarkable because they do use far fewer opioids. I
have another story. Whoa. Sue is the first vagina to receive vaginal shockwave therapy. We've actually figured out how to deliver the shockwave to the vagina.
We didn't do what we were supposed to do yesterday because we have to test that. But yes, we're trying to figure out how to do a vaginal shockwave. We know
for menopausal women, we're going to develop shockwave therapy for them. So at night, I shockwave Sue's vagina. How much fun could that be?
So the thing is that when you do radio frequency, when you do microneedling, and when you do fractional CO2 laser, you're making controlled wounds that then heal. But that's not what this does. This turns on the mesenchymal stem cells that live there to then go and make healthier tissue. So you're not doing any wounds. So so when you do a shock, you may feel a little momentary, and as soon as it stops, you don't feel it. And you don't, when we did in the vagina, you don't really feel anything. So you're making something that is so, I don't want to say unobtrusive, so mild compared to the other treatments. Although I have to say we do CO2 fractional laser, and that there's no pain when you do that in the vagina either. But to offer one more opportunity.
But that you're making an actual.
You're making a wound.
Correct. You don't do that with shockwave therapy.
Right. That's the benefit, is that you're not doing any kind of wounds. And I'm just thinking, you know what? We should do that in our patients. When you do the hymenal biopsy, we should do one vestibular treatment right then to help promote a healing.
Very clever. See, this is how we grow our research. We have So Heather and Samina, if you do come, I'll do vaginal shockwave therapy. I'll add you to my list.
That's your foreplay, is your vaginal shockwave therapy.
See, foreplay with anyone but me, thank you.
Yes, too.
No, just Sue. He talked about it with Sue, and I'm like, there's their foreplay. You're the true masters in Johnson.
I think they're doing that in the spine too, right? Aren't they shocking the spine more? And they're
Yes.
doing all sorts of muscles, right? So
Yeah.
The people at ISSWSH are a little skeptical that we're getting through the bone into the spine. So it could be that we're really doing muscles of the spine, but whatever. We do help people with
If
that.
it relieves the pain, then it doesn't really matter exactly. But I'm going to just say this. Masters and Johnson were married for about 2 to 4 years. I can't remember, before they were divorced again. So we're married 50 years. Definitely not Masters.
Oh,
Okay. He divorced his wife to marry Virginia Johnson, who already had 3 kids by somebody else. Somebody once came to our office, because California, no one's on their first marriage, and said, "Oh, Dr. Goldstein has 3 kids. How many kids do you have?" And I looked at him, I said, 3 kids. Just, "Oh, between you have 6. I said, it's the same 3 kids.
maybe we just need to replace Masters and Johnson in the future and be like, no,
Goldstein.
you're the Goldsteins.
Yeah,
That's the goal.
Yeah, you're the real masters.
You're
of
the
sex.
you're the real deal.
So I didn't start out in this world. I started out with my husband coming home every day and talking about what he did, and I just absorbed it. And when ISSWSH started, I was the first honorary member because I wasn't working in the field, and so I wasn't allowed to be a full member, but I went to every meeting and I absorbed it all. And over time, I learned a lot of stuff. And then when we moved from Boston to California, I wound up being running our clinical research because someone needed to do it. And I knew bench research because I had done that when I was younger. But I learned all this stuff. And so really, I started my career, per se, at the age of 57. And at the age of 72, 72, I think I was president of ISSWSH. So
Right.
no one should ever say, I can't make a difference in this world. No one can ever say it's too late for me to start something new. No one should ever say I don't have fancy education, so I can't do anything. Because all you have to do is have a heart, have a passion, have a brain, and put them all together and be lucky enough to have met somebody. I mean, I was Irwin, I met when we were 19. But we all have an opportunity to help other people. And Samina and Heather, both of you help people in your office every single day.
I'm so happy to work with both of you, really. It's so cool.
We love you.
Yes,
You helped us.
yeah, absolutely. We really appreciate everything you
Yes.
guys do. Every time I go to ISSWSH, even when I repeat fall courses, even when I go to the annual meeting, I always take home a good couple nuggets to use on my patients. and
Always.
it's never a wasted effort. I love it. So thank you so much for all you guys do. You guys are amazing. I wish you many, many, many more years, 50 more years together, so that you can.
Thank you.
Thank you. I'll take 25.
Yes.
Well, this is, longevity medicine is like really up and coming
Yes.
now.
I want
Oh,
to be.
the key to longevity is having good sex, by the way.
Yes, that is
Yes.
There you go.
Like, a long marriage is having good sex and being married to your best friend.
Yes.
Great. Well, that's
100%.
wonderful. I think that's a great place to end this. But thank you guys so much for giving, and there's very valuable time. So we really appreciate everything. I'm GynoGirl. Thank you for joining me. GynoGirl presents Sex, Drugs, and Hormones.
And I'm Dr. Heather Quaile, or I'm Dr. Quaile NP, and we are the Just Ask podcast.
And we're here to educate so you can advocate for yourself. And so please join us for our next episode. Thank you, Goldsteins. If you have a second, please subscribe to this podcast. I'd love for you to be a follower and learn as much as you can about the things that we're going to talk about with all the people on our journey. Please review us on Apple or Spotify or wherever you listen to podcasts. These reviews really help. Review us, comment, tell me what else you want to hear to get more information. My practice website is www.cgcchicago.com. My website for GynoGirl is www.gynogirltv.com. My Instagram is GynoGirl, so please follow me for some good content. Additionally, I have a YouTube channel, GynoGirl TV, where I love to talk about all these things on YouTube. And please subscribe to my newsletter, GynoGirl News, which will be available on my website. I will see you next time.